Here, give me a moment. I'll check on Facebook. We also go to a couple different places now as well. There we are. Let me open up that window. It seems like a few people are already queued up. It's another thing I love is people are waiting by the computer or the phone
I
for the
love that.
show. Yes, it is. Makes me very happy. But let's not keep them waiting any longer. Let's start the show.
Let's
Hello,
do it.
everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I'm your host. This episode and every episode, I am a filmmaker and a writer by trade, and I've been working with CCF for over 10 years now to create all kinds of video content, live video series like the one you'll watch today, patient-centric documentaries, treatment-based videos, conference videos, all sorts of videos, but all with the one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, if you are new to this show, I want to say welcome. And the value that I very clearly see in this show is twofold. One, the information that you will get from our guests, our experts, our specialists, and two, the support and shared experiences and stories from within the net community, which is incredibly powerful, incredibly supportive. And so if you are new to the show, I want to say welcome, and I want to urge you to, you can see in the comments people are saying hello and where they're signing on from already. I encourage you to do the same. Embrace the community. I assure you they will embrace you back. It's got to be one of the most supportive and strong communities that I've ever seen, and I am grateful every day just to be a tangential part of it. So let us know where you're signing on from around the world. I love to see the reach of these shows. And a few announcements before we get started. First and foremost, you probably know by now that we have partnered with LACNets, an amazing organization to provide a support line for those affected by NETs. That's not just patients, that's support group leaders, that's caregivers, that's anybody involved in that community that I alluded to. And that support line provides guidance, resources, referrals to NET patients, their loved ones. And so if you want to reach them, that is lacnet.org/support line. We'll try to put the link to that and any other references in the comments as the show goes on. Before we move on, I always want to thank our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. But we do have a disclaimer from them that we say at the top of every program, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts, and CCF doesn't necessarily endorse or promote any of the views, opinions, or information expressed or provided in this presentation. So, this is the crux. Audience members should not rely solely on the opinions or information expressed by the guests and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. All right. As always with disclaimers and legalese, it's wordy, but the point is this. We don't know your specific case. So we're going to give you some good answers, hopefully, to your questions, some good general advice. Take that general advice back to your home team, which does know your specific case, and make the best plan and path forward for you. I say this every episode. I am not a medical expert, but one thing I have absolutely learned in the 10 years working in this disease is each case is unique. Therefore, each path and plan forward, or plan and path forward, rather, is also unique. So use this as guidance, and you can always ask follow-up questions either at LACNet support line, or you can reach us at carcinoid.org. Now, let's get to our guest who has been on the show before. I just told him before we started he's an old veteran. He knows how to do this in his sleep, blindfolded, hopping on one leg. Dr. Jason Starr, welcome back to the show, my friend.
Thank you so much. So nice to be here. It's been some time, but it's really a pleasure and honor to join you today, and most importantly, be a resource for the patients and families and caregivers. And I'm an open book.
Oh, I love to hear that. It has been a little bit of time. It's amazing how long or how quickly rather over a year can go by these days. But we're always happy to have you on the show. Now, for those that
Thank
might
you.
not know you and your work in this space, tell us a little bit about where you work, what you do, the role that you fill in this net community.
Yes, so I'm over at Mayo Clinic in Jacksonville, Florida, the sunny Mayo, as I like to call it. I grew up in South Florida, so it was a natural progression for me to go from South to North Florida. But love it here. And I got interested in neuroendocrine um, cancers and taking care of folks with neuroendocrine cancers early on in my career. While I was at University of Florida, and then kind of carried that torch when I came over to Mayo now 5 years ago. I did all my training at Mayo, and love being in Mayo, and I love being a part of this community, as you alluded to. It's a very supportive, inclusive community from top to bottom, and in that regard, no real hierarchies in terms of patients, caregivers,
Yeah.
physicians, advocates. Like, we're all on the same level, right? But across the board, supportive, right? Our national organization, NANET's the most inclusive organization that I'm a part of, and then the advocacy groups, same thing. So it's across the board.
I got a plus one to that. I think things have changed like culturally in the medical community, but the lack of egos in this community is profound, I think. Every specialist that we've had on the show, every doctor responds in a similar way to you,
So
and they're
nice
and
to
they're
hear.
open to feedback, and they're open. It is totally a collaborative effort, and it's evident every time. Every time we do the show, every time I work with doctors with interviews and things like that, and that's just so refreshing to see. I do think. From a macro perspective, that is a shift that is happening in the medical community, but it is very clear in the net community, and I think it makes it so much I don't know, and easier to navigate the journey
I
for
was gonna
patients.
say, keeping it simple, right?
Right.
Like, we're here to help, and that's it, period, right? Like, there's no need for egos,
It's
right?
probably also just because of the need for that multidisciplinary approach. Like there is no
Yeah,
one person with the answer, and we all know that. So maybe that helps the egos drop a little bit. Not assuming that people or presuming people have the egos, but it's just like you have to
they do.
depend on your neighbor. Well, don't we all?
Most,
Uh,
yeah, yeah, yeah,
Listen, I'm
yeah.
an
No,
artist, baby. I'm all
but
ego.
right, yeah, exactly. No, but I get your point to
Yeah.
100%. But this community it does attract a certain person. It's interesting,
Yeah, yeah, absolutely. And also, I think probably some of the inherent challenges to the net space attracts a certain person too. Some of those
for sure.
question marks that we've had for years that are
It's a good point.
finally starting to be answered. It seems a flurry of activity these days, which is very exciting.
Yeah,
Folks, before we got a few questions in the queue already, which I love to see.
awesome.
Just a little bit of best practices, we'll call them. No limit to how many questions you can ask. I do ask that you formulate them in a certain way, which just helps us answer them a little more effectively and efficiently. Really, is just short little chunks is helpful. You can always come back with a follow up question, but it's really hard in this format to navigate like long paragraphs. It's hard to read. Sometimes a little bit of it gets lost in translation, and sometimes it's just too case specific. So try to
Hmm.
zoom out a little bit, and we'll work really hard to get to your answer. Um, but it's easiest if we can do it in generic little chunks like that, and you can always follow up with us afterwards. I don't want to speak for Dr. Starr, but most of our specialists
Oh yeah,
are an open book too for you to reach out to them
absolutely.
if you need to. But yeah, that really helps. And again, and if I miss your question, I don't get to all of them, feel free to ask it again. And ultimately, we get so many that we don't get to all of them. But that is kind of what keeps the engine going. So we will, one way or another, try to get you the answer to your question. That is our job. Okay, let's get into it, Dr. Starr. First question comes in from Nancy. Pardon me, Nancy. Somatostatin can cause bad diarrhea for some, like me. Have you ever heard of the same reaction from a dotatate scan? 2 months plus since the scan, but the problem is still not resolved.
Hmm. Yeah, that's interesting. I have heard of patients having diarrhea after the dotatate scan, but not persistent. I guess the question comes into, as you alluded to, the somatostatin analog, sandostatin, lanreotide. Um, they cause diarrhea. So could you be having diarrhea related to that, and it's just not being effectively addressed? Um, so the causes of diarrhea from the somatostatin analog, we should talk about that. So by the way that the drug works, right? So it's a hormone. It's a naturally made hormone in the body that we give synthetically. in a higher dose. It's an inhibitory hormone in the body that's secreted by the GI system, right? The duodenum, the stomach, the pancreas, and it inhibits secretion of certain hormones, right? It inhibits the digestive system. It can slow the digestive system down. So if we're talking about an inhibition of hormones or slowing digestion down, we think of the pancreas. The pancreas has two functions, endocrine and exocrine. So endocrine will be responsible for insulin, glucagon, right? So we think of mostly management of blood sugar. You know, that's a big job of the pancreas. But the pancreas also has an exocrine function, digesting food. Most importantly, a enzyme called lipase. Lipase digests fat. Now, amylase is also secreted by the pancreas, but amylase is everywhere in the GI system. The saliva, it comes from the salivary glands, or it's in the duodenum. So there's other places to get amylase. Lipase is almost primarily or exclusively in the pancreas. So what you may be having is called exocrine pancreatic insufficiency. It's not infrequent. I would say up to 50% of my patients. And I think I'm on the high end when I talk to some of my other colleagues. 50% of my patients are on some form of pancreatic enzyme replacement. And so that's something to consider if you think your diarrhea is related to your somatostatin analog, sandostatin, lanreotide. There's other causes of diarrhea. I can't get into all of them at the moment, but that's one that's under recognized and easy to fix.
This is what I love about you. Like, what what an education on question number one. I'm like, I'm not
I
even
gave
looking
you
at the
some
questions because I'm
physiology.
just like, yeah, oh, I love it so much. I mean, honestly, that always helps. And for me, I'm really big on kind of like you already did it naturally, is zooming out. Like, well, let's establish a few things first, and then kind of get to the specific question. So I very much appreciate that, and I appreciate you too, Nancy. Hopefully that helped. Next question from Jim. Jim says, "Good morning, Dr. Starr. Have you ever seen success with Lutathera / prrt treatment with patients without somatostatin receptors? This is a common
Mm,
issue. Looking to be headed in that direction after lanreotide has become ineffective for me."
yeah. So, and again, kind of the whole kind of taking a step back. How does PRRT work, right?
Right.
It binds to somatostatin receptors, right? Mostly somatostatin, we think of SSTR2. There's 5 subtypes. And most commonly, the one that we emphasize is somatostatin receptor 2. So if the receptor is not present, then the drug can't bind. And thus it leaves the drug ineffective. And so there is a scale in which the somatostatin expression exists, right? Um, and so we're able to measure that on a PET scan. We call it a Krenning score.
Mhm.
We scale it from 1 to 4, and that's really a way for us to speak a universal, consistent language of how much expression is present. Now, there also is a spectrum within neuroendocrine where the somatostatin receptors are present, but not in a high density and not enough to get picked up on a PET scan. So if we look at the cancer on a slide, right? Say we get a biopsy and we put the cells on a slide. There is a stain. We've talked about stains before, but think of a highlighter. There's a highlighter that can highlight the somatostatin receptors. Okay. But the question is, if the somatostatin receptors are picked up on that stain, but not on the PET, could the therapies directed at that receptor still work? We don't know. So there was some interest in terms of determining efficacy of a therapy that targets somatostatin receptors but doesn't meet the threshold where there's a receptors present on the PET scan. It just hasn't taken off because um, for a number of different reasons. One is the scientific rationale. Is it good enough to justify a therapy that can have side effects? I mean, PRRT is a risk of leukemia, right? So could you justify giving a therapy that you have a low suspicion or a low pre-treatment probability of it working? So I think the answer is if the receptors aren't present on a PET scan and the Krenning score isn't at least a 3, we usually say 3 or 4, I don't know if you could justify giving PRRT at this point in time.
Got it. Thank you so much. And thanks for your question. Hopefully that helps, Jim. Next question from Lynn. If you have nets and get COVID, will the virus cause the tumors to grow, considering you are immunocompromised prior to the COVID? And this, I mean, we've seen a rise here lately. Again, I think it's going to be kind of a thing every year at this time, it seems.
Yeah.
So what do you think about that, Dr. Starr?
Yeah. So I just got over COVID myself, and it was not a fun 2 weeks. And I think my immune system's okay, but I don't know. I'm not so sure after the 2 weeks. But as it relates to the question, the virus won't precipitate growth of the cancer that we know of. There's no interaction there where the virus infects cells, cancer cells, or otherwise, that would make that we think that there's some way that it would stimulate growth. And that's true also for the vaccine. If there's questions in regards to that, the vaccine isn't going to make cancer grow. There's other questions about the vaccine and that we could talk about that comes up often. Now, as it relates to the immune system, right? So, got to consider what the immune system is doing at that point in time. The drug everolimus Afinitor um, is very immune suppressive. It is a drug that we use in organ transplant to suppress the immune system. It knocks down T cells. So if you're on everolimus and you get COVID, could you get more sick than you would otherwise? The primary mechanism for the body fighting viruses is T cells. So if your T cells are suppressed, you could, I would imagine, and we don't have data per se, but you would be more sick. We do know that patients who are immune suppressed are higher risk for developing more severe COVID, right? Even to the point where it may justify the administration of antivirals for COVID. So it really depends on the therapy that you happen to be on. Now, if you're on a somatostatin analog, sandostatin or lanreotide, that shouldn't affect the how sick you get from COVID, right? PRRT can suppress the neutrophils and the lymphocytes, so that could potentially make you more predisposed to having more severe COVID. So really, you got to really think about it. You can't really paint with a broad brushstroke as it relates to your risk of a severe infection with COVID.
Got it. Thank you. Thanks, Lynn. From Sarah, is nets possible in bile ducts causing narrowing slash stricturing?
Mm.
Yeah. What and the second question, what should be done to look into the stricturing that has unknown cause?
Oh yeah, good question. So neuroendocrine tumors can arise in the bile ducts. It is super rare, one of the more rare manifestations of a neuroendocrine tumor. I have seen it. And so, how could you investigate that? A few different ways. One is called an ERCP, where they go into the esophagus and they essentially go backwards up into the bile system. So, that's one way to evaluate the bile ducts. Sometimes the ERCP only gets to certain areas of the bile duct. So there's a special technique, something called a spyglass, which I think of it like a telescope off of the scope, where you can go a little bit deeper into the bile system and you can visualize it a little bit better. So that's typically how we would evaluate the bile system. An ERCP plus or minus that spyglass. If another modality that's helpful for evaluating the bile system is called an MRCP. So this would be an MRI, but focusing on the bile system and the pictures really honing in on that bile area. And that's another way you can evaluate the bile system without doing an invasive procedure, or at least get like a lay of the land so that the endoscopist knows what they're going after, if they do go in with an ERCP.
Got it. Hey, thanks, Sarah. Next question from Roberts. Can metastatic tumors spread to distant sites in the same way as primary tumors?
Mm, yeah, this is a really complex question. It kind of hints at tumor biology, tumor kinetics, meaning growth of cancer. It is not predictable. There are certain cancers and there's certain models, mathematical, computational biology models that can predict risk of metastasis, for example, based on the size of a tumor, based on the underlying biology of the tumor. There's no way to reliably predict a tumor in the liver is going to shed cells that are then going to show up in the bone. I would say, as a principle of oncology, we think of the cancer stem cells arising from the original tumor and kind of shedding out into the periphery. And again, this is a better question for a PhD. Not that it isn't a good question, but maybe I'm not qualified to answer it. And so I think there's no reliable way to really predict whether a tumor that is metastatic can lead to other metastatic sites.
Got it. Thank you. Appreciate your question, Robert. Folks, if you joined us a little bit late or just joined us, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. Today, our guest is Dr. Jason Starr from Mayo Clinic, and this is our penultimate show of 2023, which is crazy to
Oh,
imagine.
wow. Yeah.
Yeah, so we're getting close to the end of the year. If you love this show, send a heart in the comments. Look at that.
Oh,
My
that's so
gosh.
warming, so heartwarming. That'll
And
make us happy.
stay tuned for announcements about the continuation of the show next year and what that might look like in the forthcoming weeks and hopefully before the new year. So let's keep this show going while we have Dr. Starr and his time. Plenty of time left, plenty of questions as well. Next one comes from Lori. Okay, this one might open the door to a few questions or topics. Thank you for your time and expertise, Dr. Starr, first of all.
Pleasure.
Do you know of any upcoming clinical trials specifically for grade 3 well-differentiated PNETs? That is very specific, but then we can also maybe zoom out as well and talk about other trials perhaps.
Yeah.
So let's address Lori's question first.
So finally, grade 3 tumors are getting some attention that the disease deserves. Historically, I think it was Lori you said, as Lori was alluding to, we've focused a lot of our efforts on grade 1 and 2 tumors, and then the medical community, the neuroendocrine experts who are kind of developing trials, the pharmaceutical companies who are working with neuroendocrine experts to develop trials, recognize that this is a severely underserved population. Grade 3 in general, PNET or otherwise, right? So if you look at a lot of the trials right now that are being developed or are reporting out, for example, the NETTER-2 trial, which reported out at ESMO recently, which was essentially, NETTER-1 was the original PRRT trial that essentially got it approved by the FDA. NETTER-2 was moving PRRT up to the front line in terms of first line before patients are even put on somatostatin analogs, lanreotide or sandostatin, and included grade 2 and 3 tumors, GEP-NETs, gastroenteropancreatic neuroendocrine tumors, well differentiated. The other trials that are going on right now in terms of PRRT are also inclusive of grade 3 tumors. Now, PNET is one of the diseases, especially grade 3, and otherwise, about 10% or so are somatostatin receptor negative, at least on PET imaging. And so maybe PRRT is not an option. The recently reported out trial of cabozantinib, or Cabometyx is the brand name. The Cabinet trial did include, I'm trying to think what the cutoff was. I think it included some grade 3 patients, or at least up to 20% on the Key 67. So, you know, we're trying to be more inclusive. There is some new evolving drugs, I should say, or therapies that are looking at neuroendocrine carcinoma, but we're trying to see if the same receptor, for example, one receptor called DLL3 that is present in a lot of neuroendocrine carcinoma, is also what's the receptor presence on a well-differentiated neuroendocrine tumor, right? That's because the difference is, right, just the way it looks under the microscope. we think that there is DLL3 expression in well-differentiated neuroendocrine tumors. So, you know, the folks, these are pharmaceutical companies who are developing these trials, are listening to us and saying, okay, well, maybe that's a group of patients that we should focus on, because again, it's historically been a group of patients that hasn't been represented in the clinical trials. So I think, the theme of what I was just mentioning is a lot going on for grade 3 right now. The mainstay for a well differentiated grade 3 in terms of treatment really does depend a lot on the Key 67, or sometimes called the Ki-67. We use this cutoff sometimes of 55% to kind of decide on which direction we should go. But chemotherapy tends to be the mainstay. But we presented a poster at NANETS, our North American Neuroendocrine Tumor Society conference in Montreal that happened last month, which was a blast. It was great to see everybody there. And we looked at, I think it was like, I don't know, 5 or 6 patients with pancreatic neuroendocrine grade 3 with cabozantinib, cabometrics. Because I mentioned the cutoff on the cabinet trial was 20%, so right up to grade 3. And we saw some pretty impressive responses initially, and a couple durable responses. So maybe cabozantinib is an option. In the process, I just was able to obtain that for a patient of mine after a couple appeals. So something to consider. We extrapolate a lot of the treatments for grade 3 for pancreatic neuroendocrine from what we do for grade 1 and 2, for better or worse. My hope is over time that's going to change as the disease gets more attention.
Got it. Thank
That
you.
was a long answer. Sorry.
No, we call that thorough at Luncheon with
Thorough.
the
Okay. Thorough.
Experts.
Thorough, long, winded.
We like thorough. We like
Okay.
thorough.
Okay.
Yeah, yeah, yeah. Next question from Joy. Joy says, I'm curious if patients do not have carcinoid syndrome, they are showing tumor growth, and they're going to have prrt. Do they typically continue on Somatostatin, being it doesn't appear to be working for tumor control? What would be the reason to continue with those shots?
Oh, that is such a good question.
You know our,
We
our
talk
community.
we talk about this all the time, and I feel like there's 2 camps. There's one camp, so the Netter 1 trial, and the Netter 2, I believe, Netter 1 for sure, they continued the somatostatin analog. Remember, Netter 1 was enrollment after progression on somatostatin analog, and then continuation of it, thereafter on the PRRT. The control arm just doubled the dose. I'm in the camp where, if a patient, as you alluded to, does not have carcinoid syndrome and the therapy is not working, I don't see a reason to continue it. There's no, unless somebody can give me some good scientific rationale. There was some talk about whether or not the somatostatin analogs upregulate the somatostatin receptor, so maybe it makes the receptors more available. I remember reading a paper on that, but we give the somatostatin receptor analog after the PRRT, either the same day or the day after. So that doesn't hold weight. So to answer your question, I'm in the camp that I can't find a good reason to continue it. It's expensive. Um, Unless somebody can, give me a good scientific rationale, or we have better data. We've been talking about this at the national level in one of our cooperative groups called the Alliance. Dr. Tricolinos is proposing a trial that we're still working through on whether continuation of somatostatin analog versus discontinuation, essentially, so we can finally have some data to provide to you as the patient to say, yeah, this makes sense to get this shot in your butt that hurts and can leave these bumps, and you got to go in. I'd rather not have to get it if I was in that position. And I'd rather you not have to get it if it doesn't help. So I'm in the no somatostatin analog camp, or no continuation.
Got it. Thank you so much, and appreciate your question, Joy. Hopefully that helped.
That was a good one.
Next question from Eva. Does Mayo plan to purchase the equipment and training for histotripsy? And I actually know what this is.
Oh, yes. Well, I love this question.
We get this question a lot lately.
I got this question 3 times this week.
Really?
Yes.
All right.
So this was developed. I looked into it earlier because my patients, you all are so savvy. You heard about it before I did. So it was being developed at University of Michigan by a brilliant scientist. And sure enough, they started doing studies. They're like, yeah, it looks like this may work.
Let's
Yeah,
pause and establish
talk
what
about
it
what it
is.
is.
Yeah, yeah. First,
Yeah,
because I'm glad this is totally new
yeah,
ish.
yeah. Good. Yeah, let's take this step back. So, histotripsy is essentially a device that delivers ultrasound waves on a frequency to potentially disrupt cancer cells and destroy cancer cell walls and make the cancer cells die. It's a very simple concept. We're looking, at different techniques like this. For example, there's another modality called tumor treating fields, which is electromagnetic energy to disrupt the cell walls. We have a
Nice.
trial here at Mayo for that for pancreas cancer. And so we also have something called radio frequency ablation, where this one's a little more invasive, not a little more, a lot more. You got to put a catheter into the tumor. And again, it emits energy and destroys cancer cells. There's cryoablation, put a catheter in, and then, it freezes the cancer cells. So this is a non-invasive approach where they put the ultrasound probe on, and the ultrasound with the frequency and the energy destroys the cells. I don't know that much about it other than what it is. I don't know the data very well. I think the data is still evolving. The FDA approval for a device is a lot different than in terms of the rigors than for a drug.
Mhm.
Now remember, this is a non-invasive technique, right? They've established safety. So once you establish safety, I suppose with something like this, the efficacy data or more efficacy data can come
Yeah.
thereafter. But I heard one of my patients is seeing Dr. Eric Liu over out in Denver, and said he's purchasing one. So to answer Eva's question, um, will it work in neuroendocrine? I don't know. Does it work better in some cancers as opposed to others? I don't know. Will Mayo purchase the equipment to do the treatment and study it further? Almost certainly. I haven't. It would be performed by our interventional radiology colleagues, so I have to talk to them, especially on the heels of the recent FDA approval, and see where this is going to go. But it's exciting, and I love the fact that it's non-invasive.
Yeah.
That's the best part of it.
Yeah. Yeah. I'm sure the patients do too. Yeah. Yeah.
Yeah,
Yeah. Well,
I
thanks,
try to
Les.
avoid recommending a needle in the body at any cost.
Yep. Heard. Absolutely. Thanks, Eva. Appreciate you. And quick question from Leslie, who's joining us via YouTube, and this applies to everyone. Just missed the first question. Is there a way to view the first minutes? Yes, absolutely, but not until the show is over. Once the show is over on all platforms, it will be automatically posted there and live there natively. So you can always go back and watch these shows. And in fact, all of our channels, YouTube, Facebook, has a catalog, a database with them nice and organized, and you can always revisit these. But
Nice.
while it's live, you can't necessarily go back and watch the first minute. But as soon as the 1 o'clock hour Eastern time hits, you will be able to. So thanks for joining us via YouTube, Leslie. Now, let's talk about immunotherapy. It gets brought up every now and then these days. Jim says, do you see immunotherapy as having a higher potential for an actual cure to NETs in the near future based on early signs? That's a big question.
Oh yeah. Um, Immunotherapy is not a panacea. Um, it it's not in theory, it makes perfect sense, right? Like it's the most beautiful kind of illustration of science that you could ever come up with. Activate your immune system to fight the cancer, right? Unfortunately, it's much more complicated than that concept. Um, Historically, to date, for well differentiated tumors, immunotherapy has fallen short. It, the drugs that we have that have been successful in melanoma, lung cancer, a number of different Hodgkin lymphoma, it doesn't work. It doesn't work in well differentiated neuroendocrine tumors. So the question is in the call to order is how do we make the immunotherapy work, right? How do we augment the immune system in a different way than we are with our traditional immunotherapy approaches? And that's an open question. There's different targets on the cell. There's different ways to activate the immune system, but you got to be careful. If you activate the immune system, it could attack your own cells, right? So you're trying to find this balancing. You're doing this balancing act between attacking foreign but not attacking self. And that is a really delicate balance, right? Um, and so we've had more success in neuroendocrine carcinoma, a more aggressive malignancy. Uh, there's probably more DNA. Well, there's more DNA disruption. And it appears that the DNA disruption is more of a marker for the immune system to recognize cells as foreign, essentially. So any activity that we've seen in with immunotherapy has been in neuroendocrine carcinoma. I alluded to the DLL3 target as a potential target to enhance the immune response once, because sometimes what we could do is if we find a target, for example, somatostatin receptor, that one's a bit of a slippery slope, and I'll tell you why. You can also design an antibody. See an antibody in the back here? You can also design an antibody to attach to a T cell. So you could attach it to the tumor cell. You could bring the T cell to the tumor cell and say, look, this it's an invader, it's foreign. We've done that and it's called a bispecific antibody. The problem with somatostatin receptor as a target is that it is more ubiquitously or diffusely or kind of expressed. I'm trying to think of another way of saying it. It's expressed in a lot of places in the body. The whole GI system has somatostatin receptors. So if you start going after somatostatin receptors, guess what? You're going to start attacking your own body, most likely. And I've seen that happen with a study drug that went after somatostatin receptor, tried to bring the T cell close, and there was some really bad gastrointestinal side effects. So I think the immunotherapy is a worthy pursuit as we continue to try to develop a way to, um, you know, find. We continue to try to augment the immune system, but do it safely. There's something called CAR-T, which maybe you've heard about. Essentially, we in medicine bioengineer T cells. So we take T cells, for example, from the patient, or we make T cells. We develop them in the lab, and we train the T cells like an army against a target. And then we infuse the T cells into the body and say, "Go, everybody! Break out, go after the target." Um, it's worked really well for hematologic malignancies, has been slower to develop for solid tumors like neuroendocrine cancers. So again, that was a thorough answer, but I think it's worth a discussion for sure.
Oh, absolutely. It's not easy for a one word answer to that
Yeah,
question.
no, yeah, the one word answer is in well differentiated neuroendocrine doesn't work.
Got it. Got it. Okay, next question from Kim. Kim says, can you stop lanreotide after 5 years if CAT scans are not detecting anything?"
Yeah, yes. That'll be a short answer.
That is a one word answer.
Yeah, that is a one word. Yeah, I think if you're in a situation where there's no evidence of disease, you have to wonder why you're still continuing the injections anyways. Not you, but just I'm
Mhm.
just speaking hypothetically. So you could always stop it, do scans, in a certain interval, and if nothing shows up, hey, great call. But the answer is yes.
All
But
right.
that's not medical advice.
Fair. Totally fair. From Julie, more diarrhea questions. Post recovery after small intestine surgery, what can be done for continuous
Mm.
diarrhea? No carcinoid syndrome. Could it be malabsorption?
Ooh, great question. All right. So these are really practical questions, which I love because a lot of times as a physician, I could potentially fix it, which is a great feeling. So another underrepresented, or sorry, underdiagnosed entity is called bile acid diarrhea. We call it BAD. Um, and this is well recognized and very much underdiagnosed. So what happens is when you have some of your small bowel removed, typically your terminal ileum, that's where the most common place we find these neuroendocrine tumors. And guess what? In the terminal ileum, a few things are reabsorbed for the body. It's right where the small bowel meets the large bowel. One is bile acids. The body's very efficient. So the bile acids are reabsorbed and essentially recycled and used again. Well, they're absorbed in the terminal ileum. B12 is also absorbed in the terminal ileum. So if you don't have a terminal ileum, you could develop B12 deficiency. As it relates to the diarrhea question, there is medications called bile acid sequestrants, which will bind the bile acids because you can't absorb them, right? So if your body can't absorb them, sometimes they can be a cathartic, meaning they cause diarrhea. They want to come out, right? And so the bile acid the resins, the sequestrant, bind them and neutralize them, so that you don't have this flood of bile acids coming out as diarrhea. So that's low hanging fruit, under recognized. Now, the question alluded to something called short gut syndrome, and you know, usually for that to happen, you have to have had like at least 200 centimeters of the small bowel removed. So if less than that was removed, it's likely not short gut. But that's also a possibility, and I always recommend speaking with a gastroenterologist or the surgeon who did the surgery to say, hey, could short gut be present based on how much small bowel you removed? A more common scenario is the bile acid diarrhea, and it is an easy fix. There's a blood test to confirm whether you could be having bile acid diarrhea. It's called a 7AC, and I can't remember what it stands for right now. But essentially, what it does is it determines how well your body is in terms of recycling bile acids. If the test is elevated, it means not very well, because this enzyme, I think it's an enzyme or it's an actual precursor of the bile acid, the bile structure, the chemical structure. I can't remember. But if it's elevated, it means that you're not efficiently recycling, and that's a possibility if you're having the symptoms.
Got it. Thank you.
Sure.
Um,
Bad, right? That's the take home.
bad. Yeah, bad. Um, I've gotten this question before. Certainly, this is from Kat. Kat says in 2020, I had the 4-session prrt. Understanding FDA approval is based on 4 sessions.
Hmm.
If the remaining tumor starts spreading again, is there research or plans for maybe a 5th or 6th round, or is 4 and no more?
Yeah. Ooh, that's a timely question.
Hmm.
So they just launched an NCI trial called the Net Retreat, and essentially it's going to ask this question: is can we retreat with PRRT, the commercially available Lutathera, and does it work? So I will say at Mayo, we've probably done, oh, I would say 50 patients so far where we've treated beyond the 4 cycles. I have one patient where we treated with up to 8. I think I spoke to my mentor, Dr. Havdanerson, or it was Dr. Johnson, who's a nuclear medicine expert at Mayo, and they said 10 or 12 treatments. So it really depends in my mind, and the trial is going to help answer this. It really depends on how long did it work on the first go round, right? So for entry of this Net Retreat trial, which is being led by Dr. Shahan, I can't remember maybe Dr. Singh. So I give them some shout outs. We're all friends in that community, in the net community. So patients had to have stable disease for 12 months upon completing the treatment. So essentially, you want to make sure if you're going to give a therapy that you have some confidence that it worked on the first go round. So I would say for this patient that asked the question, I forgot name, sorry. Um, if the treatment worked for, again, right now it's arbitrary, but at least 6 months, then it wouldn't be unreasonable to go back to the well if you tolerated it. And so the answer is yes, you can treat beyond 4, and I have many a time now.
Got you. Thank you so much, and thank you, Kat. That was Kat, of course.
Kat,
Kat.
thank you, Kat.
Folks, we got about 15 minutes left. We're going to try to get to as many questions as we can. Susan says, "Thank you for your explanations, your thorough explanations.
Yeah, there.
You are so good at explaining things in a clear manner. I have to agree with that.
Thank you.
I've learned a lot today myself, and I hear a lot of these questions often. And Angela says, "We love Dr. Starr." I so agree, Angela. I
Oh,
so
that's so
agree.
nice.
And folks, stay tuned before the end of the show. We're gonna. I have a special question for Dr. Starr that you may not have heard about or thought about in the net space. Let's continue taking
Hmm.
some more from you all. Are there other drugs than Zermello to control serotonin? Zermello's primary focus, as I understand, is to address diarrhea, which I don't have. Secondary, control serotonin. Let's take it there.
Oh yeah. Okay. So at Nanitz, Dr. Ear, who is a brilliant scientist, PhD scientist at University of Iowa, is doing this basic science research in terms of the effect of serotonin on the growth of the cancer, and whether or not blocking serotonin has any effect on how the neuroendocrine cells divide. We also know that serotonin plays a role with immune system and maybe immune suppression, right? And so maybe that's why neuroendocrine tumors don't respond to standard immunotherapy. Maybe that the serotonin is creating this immune suppressive environment. Now, admittedly, not all neuroendocrine tumors secrete excessive serotonin, right? So this is just postulating based on a scenario in which serotonin is being secreted. Rain, can you go back to the primary question?
Yes, give me just a second.
I was going to try to answer it a little bit more directly.
Yeah, she's Kat said, are there drugs other than Zermello to control serotonin?
Ah, so so the somatostatin analogs decrease serotonin uh, granules, secretory granule expulsion from the cell. So that's how it works in carcinoid syndrome, the somatostatin analogs. But again, not all neuroendocrine tumors, secrete serotonin excessively.
Mhm.
So the question is, and the majority we don't think actually secrete serotonin excessively. Now, could the neuroendocrine cells be secreting like a baseline level of serotonin that's maybe subclinical? Yes. But to answer the question, we don't really target serotonin unless it's causing a syndrome, right? Unless it's causing carcinoid syndrome. So if somebody's not having carcinoid syndrome, the serotonin is not a target as of now.
Mhm.
But some of Dr. Ear's work could change that, and we'll see where that research goes. But it's a really intuitive question, and a really smart question.
Thanks, Kat. Next question from Nancy. And Nancy, thanks for pinging me back again to remind me. I did go back up to the comment section and find your previous question. Question is, Dr. Starr, have you seen someone with unexplained weight gain? And here's some details: lanreotide, bowel resection, liver debulk in the past few years, thyroid and cortisol is normal.
Hmm.
30 pounds with no reason. She also specified that it's like barrel shaped, which is not how
Hmm.
women in her family would gain weight.
Hmm.
And she's always been thin, but the numbers keep climbing. So she's very confused.
Interesting. Yeah, that's probably a better question for an endocrinologist or a bariatrician. You alluded to there was no hormonal imbalance, whether Cushing's, like a cortisol excess,
Right.
a sluggish thyroid, right? So those would be the
Mhm.
things that I'd be thinking. There could be some other metabolic parameters that aren't being assessed within those numbers, right? And doing strict calorie intake, and basal metabolic rate, all those things would need to be plugged in. So nothing that I can identify that would be like, that'll fix it. I think it needs a little bit more workup
Right.
and some thoughtfulness from from the medical side to
Sure.
try to figure out what's going on.
Got it. Got it. Thank you. Next question from Jim. I totally hear the comments on PRRT. Where would alpha PRRT come into play?
Oh yeah, love an alpha question. So so right now, the study that's, I would say, furthest along, is actinium, which is through a company called Raise Bio. They have the Action One trial, and what we're looking at is open at Mayo Clinic, all three Mayo sites. They're looking at patients who have progressed on Lutathera. So, as I alluded to, we want to make sure that we're selecting patients who seem to have benefited from the initial Lutathera. So, patients had to have been stable for 6 months upon completion after that treatment to be eligible for this trial. And so, I can't remember what the key 67 cutoff is at the moment, but I believe that they are including some grade 3 patients. A cutoff that's been is a bit arbitrary, is sometimes 55%. Is that you'll hear that cutoff a lot on the key 67. So right now, to answer the question, alpha particle therapy is being studied for patients who progress after progression of on Lutathera. So the question comes in: so what's better, PRRT beta particle, which is the Lutathera retreatment, or alpha particle therapy? And that I don't have. I mean, I'm just creating the question because it's a logical next question. There is another company, ITM. I can't remember. I think it's called Template Pharmaceuticals. I think the name of the company is, or Integrated. I can't remember. Integrated Template maybe. And they have an alpha particle. They have a compound which is lead, and they are looking at patients. They're really more on the safety side because the actinium's further along, so the lead radionuclide is earlier, so they're still looking at some safety. So they're including patients who you did not necessarily had to have had PRRT yet. But again, that's a non-randomized study. The Action One trial that I mentioned is randomized, meaning 50% of patients are assigned to the alpha particle, 50% of patients are assigned to a standard of care, no placebo. So those are the two of the alpha particle therapies. The Action One or the Raise Bio is further along and accruing very quickly.
Got it. Got it. Thank you. Still got time for a few more questions from Laurie. Why isn't captem or captem as effective for lung nets? It seems to work better on P nets.
Hmm. So the question is, or the question's great. The answer is, I don't know that that's true per se. Most of the data that we have is in PNET. We do have some data in small bowel, mostly like series, retrospective, kind of institutional experiences, where it is effective, but not quite as effective as in PNET. One reason could be, so capecitabine historically has been most active in gastrointestinal malignancies. And so that may be a reason why the CAPTEM combination is more active in gastrointestinal malignancies as opposed to lung. Because it is true, I think if you look at the data, lung net, depending on if you could say, we call it lung carcinoid still, unfortunately, but typical and atypical.
Mm-hmm.
If you look at the atypical carcinoid, it's a more aggressive disease than pancreatic neuroendocrine, which is more aggressive than small bowel neuroendocrine. So you may just be dealing with a more aggressive cancer, and so the CAPTEM isn't as effective because the cancer is more aggressive. But I think the temozolomide is actually the most powerful drug within the CAPTEM. Because if you look at the study that kind of put CAPTEM on the map officially for PNET, it was CAPTEM versus TEM. TEM did pretty darn good on its own. CAPTEM did a little bit, did better, but TEM did really well on its own. So I think CAPTEM is a reasonable treatment for atypical carcinoid of the lung. I don't know that we've identified the most effective therapy in that disease. We only have one FDA approved drug for more of the typical side, the Afinitor, the everolimus. There is a national trial going on right now led by Dr. Tom Hope at UCSF looking at PRRT
Mhm.
versus everolimus in lung carcinoid. The caveat there is that the somatostatin receptors, to the extent that we feel like the prrt would be beneficial, is only present around 50% of the time.
Got it.
So that's the caveat.
We talk a lot here in this space about quality of life, and we all know that the net community is very well educated and learns all the like the histotripsy question that we had. They're always on
Oh
the
yeah.
cutting edge, and we were talking earlier before the show about a new study that you're working on, which I would say
Mhm.
is kind of cutting edge too. Can you tell me a little bit about what you have on your plate currently?
Yeah, absolutely. Yeah, I got to say the questions are
So
phenomenal.
good,
I
right?
mean, they
So
might as well
good.
be coming from doctors and medical folks. So you guys, I mean, are spot on and just so bright. And I got to commend each one of you for bringing great questions. So thank you. Um, so I started down a ex- exploration journey right around the pandemic. And the reason why is because I was seeing patients who were suffering from existential distress, or what we call sometimes in the medical community demoralization, related to their cancer. Um, and what does that mean? Well, it means that somebody is feeling hopeless, has lost meaning in their life, paralyzed by the fear of their their mortality, essentially. That's the best way I could put it. And not able to live, and not able to live in the moment, and not able to enjoy the time that they have, no matter how much time any of us have, right? But when you're faced with a terminal illness or an incurable disease, that time appears a lot more finite. So I stumbled upon a book that Rain already knew about, called How to Change Your Mind. It's written by New York Times bestseller Michael Pollan, who's an incredible author, who's written on a lot of different topics: food, caffeine. And so he went down as an exploration of psychedelics. And, psychedelics were, um, you know, stigmatized back in the 60s with Nixon's war on drugs. And, at that time, it was a different era, right? There was research that was evolving. Most, at Harvard, there's a guy, Dr. Timothy Leary, who was giving all of his students LSD. Um, but there was this science community evolving, and it really got suffocated with the war on drugs. And then, oh, about, I don't know, 10 years ago or so, and it was evolving before that. The 10 years, there's been this renaissance in terms of studying of psychedelics. What do we have here, right? And the psychedelic that I'm most interested in is called psilocybin. It's derived from naturally from the magic, we call the magic mushroom, a family of mushrooms called psilocybes, and can be made synthetically in the lab. And so there was some pioneers, some brilliant doctors and scientists who said, okay, well, you know, and I could talk. I told Rain I could do the whole hour on this, literally. But essentially, people who experience psychedelics would report a mystical experience, an experience of connectedness with the universe, that things made sense to them, that they were relieved of mental burdens that they had been carrying. So the landmark trial was at Johns Hopkins. I would say reputable, one of the most
We
reputable
could argue that, yeah.
scientific institutions in the world. Dr. Roland Griffiths, who just passed away from colon cancer, what a amazing human. Did a trial in 51 patients, and 2/3 of the patients reported that their psilocybin experience, and these were patients with cancer who were suffering from anxiety and depression, not specifically demoralization or existential distress, but along that spectrum. 2/3 of those folks reported that it was a top five most meaningful experience of their life, and or most spiritual experience of their life. And so this sent me down this path of research, reading. And now fast forward 3 years, I'm developing a clinical trial where I want to study psilocybin in patients with demoralization related to cancer, and doing it in a different way, a different delivery, as far as how to do that best. And so I'm really excited because I think that this could really make a difference in my patients' lives. Um, and yeah, I'm in the process of applying for a grant, looking for funding elsewhere. But it's very meaningful to me because I feel like it's an opportunity for me to give back to the community, humanity, and help folks through a difficult time. Um, so that's where I'm at.
Yeah, I think it's so interesting, and some of the people in the comments are asking more about that. I'll just say that do your research. There's a lot of connotations that come with things like that, but I
Hmm.
also know that this community is very open to holistic approaches and learning more and more about what might help them. It's all about quality of life, and the first thing I said in this episode was each case is unique. So what helps people forward is unique as well from my outside experience. One of the things we do here at the foundation to help with that is we create these documentaries, and I had one that just came out earlier this month or last month. We're in November now. That is, if you haven't seen it, watch that. But it's very hopeful and shows how people psychologically and emotionally navigate this rare disease in the efforts of that peak quality of life as well. So check those out. That is our show for today. We're at the 1 o'clock hour. A couple of things, folks. I won't see you again until December, where we will finish off with Dr. Kuntz,
Oh,
another rock
great.
star in
That's
the
a grand
community.
finale there.
Always, always. And in the meantime, two things. Happy early Veterans Day this week, and a special extra slice of love to any net patient veterans. And if you know any, I'd be really grateful if you'd send their contact information or their names in the comments, or you can send it and message us. We'd love to highlight them if possible. That's this week. And if you celebrate, Thanksgiving is right around the corner too. So make sure that you spend time with your loved ones, and or reach out into the community, connect with people. That's what it's all about, whether family or friends or other people in the net space, the community we have here.
Spread that love.
Absolutely spread that love one way or another. Dr. Starr, I appreciate you spreading your love today and knowledge with us as always. Thank you for being here.
My pleasure. Thank you for having me. You do such a great job with the moderating, and a gentleman and a scholar. So great
I do
job.
a good job listening and not interrupting too much.
That's a very rare skill.
It took me years to cultivate, sir.
Well,
Uh,
you're good at it.
and thanks to you all at home, as always. We hope we answered some of your questions. And if you have follow up questions, of course, I'll reiterate, reach out to us at carcinoid.org or lacnets.org/support line. As always, thank you to Ipsen Biopharmaceuticals, our presenting sponsor. We couldn't do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone.